The topic today, as we're continuing this series on aging bones, is on pelvic fractures, which I'll be talking about, and also spine fractures, which are some of the more complex injuries that we treat as orthopedic trauma surgeons. And Trigg, with his expertise in both spine and trauma surgery, is uniquely qualified to talk about that. But I'm going to kick things off and start off talking about pelvic fractures. So we'll start off, this is just kind of a quick overview. We'll go through a little bit of the anatomy of the pelvis. It's one of the more complex areas that we deal with in our specialty. We'll talk a little bit about different types of injuries, just in sort of broad categories that we typically see, and how that varies as we get older in terms of what types of injury patterns we see, as well as injury mechanisms we see. And then we'll talk a little bit, just in broad strokes, about kind of how we approach treatment of the diverse types of injuries that can happen to the pelvis. So when we talk about the pelvis, what do we mean specifically? So the pelvis, in the most basic terms, from a biomechanics standpoint, is what connects your spine to your hips and your legs. So it transmits a tremendous amount of force from your legs up through your hip joints and into the pelvis and up to your spine. And the front of the pelvis is made up of, on each side, we call it the innominate bone. It has three parts, but they're really kind of fused together into one part. But they're called the ilium, the pubis, and the ischium. Those three make up this innominate bone, which is kind of each half of your pelvis is one innominate bone. And they meet in the back at an area called the sacrum. And the sacrum is actually, Trigg will get into it to some degree, I think, is it's actually part of your spine. It's the lowest part of your spine. But we also consider it part of your pelvis, and it forms this ring of stability that transmits load from the spine in the back up to your hips in the front. It's joined in the front by a lot of ligaments, and I'll talk a little bit about that, because that's a really kind of critical part of the anatomy. So this innominate bone and the sacrum, they don't they're not like this perfect ball and socket joint that naturally stays together because of the way they're shaped. They stay together because there are big, strong, stout ligaments that hold the bones together. The joint in the back that connects the sacrum to the rest of the pelvis is called the sacroiliac joint. So you may have heard people talk about sacroiliac joint problems, but it's in the very back of your pelvis, again, where the spine meets the pelvis. And it's covered by these extremely thick ligaments that are like ropes that hold the back of the pelvis together. And this is really important when we start getting into pelvic injuries, because these play an important role in providing stability and determining what a stable injury is from an unstable one. In the front of the pelvis, you have these two halves of the pelvis, the two halves of the ring coming around to the front, and they meet at an area called your pubic symphysis, and you can feel this kind of right in the front of your pelvis. That's the prominence in that area. And there's a thick fibrocartilage attachment right in that area that's very dense and strong as well. This is the area that in pregnant women who are going to give birth, it actually loosens up a little bit and allows that pelvis to open up to allow a delivery to occur. But it's a very important ligament. It's normally very stout and very rigidly held together. And so that's important as we think about what the different types of injuries are. So again, just to recap, the pubic symphysis is in the front. We have the sacroiliac ligaments, sacro for sacrum, iliac meaning the iliac bone was that first part of the innominate bone. So the sacroiliac ligaments, and they have, there's a front part of those ligaments and then a back part of those ligaments that make up, so those are really the three major groups of ligaments that hold these pelvic bones together and play a role in pelvic injuries. You can't talk about pelvic fractures without talking about some of the major important structures that go by it. So we'll kind of go through each of these in a little bit of sequence. So the blood vessels are obviously very important. The aorta comes down and it branches into your iliac vessels. The iliac vessels are the two big branches of your aorta that provide blood supply to your leg. They have one branch that goes inside the pelvis and supplies blood to all your organs that sit within your pelvis, and then another branch that goes down into your legs and supplies blood supply down to your feet. That has two important implications. One is that when you break your pelvis, can be an awful lot of bleeding. And so these are, in orthopedics, we don't have a lot of, we consider ourselves saving limbs a lot of the time, but these are injuries where sometimes it's very life-saving because there can be so much bleeding that there can be life-threatening injuries in many cases. It also means that if you disrupt one of these, then you could lose blood flow to some of these organs or to your limb. And so these are higher risk injuries than many of the other ones that we commonly talk about. The nerves are also major nerves. So all these major nerves that emerge from the lower part of your spine pass through the pelvis. The biggest one's your sciatic nerve, which I think most people have heard of their sciatic. So your sciatic nerve comes and passes through the back of your pelvis and goes down the back of your leg. It supplies most of the muscles in the back of your thigh and lower leg. And also the femoral nerve is the other major nerve that passes through. And the femoral nerve goes and supplies your quadriceps muscle. And so anytime you have an injury to the pelvis, there's this risk that you might have a nerve injury that could lead to potentially like a foot drop. It would be something that we would commonly see because of the sciatic nerve being injured. You can also, there are nerves that go to supply all the organs within the pelvis. So people can have problems with bowel or bladder function because of the nerves that supply those areas. So this is another major consideration in talking about pelvic fractures. And lastly, what are the sort of pelvic contents that we're talking about? What are the pelvic contents that we're worried about in a pelvic fracture? Well, almost all of your lower abdominal contents, your intestines and everything, are sitting kind of adjacent to your pelvis. The ones that are mainly within the pelvic ring would be the bladder, the uterus in women, and the lower part of the GI tract. So any of these can be injured in association with a bad pelvic fracture. So this is always something that we're thinking about. This isn't just a broken bone. All these other structures are also at risk and can cause significant long-term problems for people. So just to summarize the anatomy part before we jump into the injuries. So there's a really complex anatomy surrounding the pelvis. The bony injuries can be associated with major ligament injuries and instabilities, vascular injuries, nerve injuries, and bowel and bladder injuries. And not only is that complicated for the injury, it also complicates our surgical treatment because exposing the pelvis is not just a little skin incision. It usually involves quite a complex exposure that has to take into account all of these different anatomic structures. And that has relevance as we talk about treatment a little bit later. So what are the injury patterns that we typically would see for the pelvis? So I'm going to put it into two kind of big, broad buckets that we would typically see. The first is a pelvic ring injury. So a pelvic ring injury, we always use the analogy of a pretzel. It's literally, you can't really break a pretzel in one place, you know. It almost always breaks in two, and the pelvis is the same way. And that ring that goes from the pubic symphysis in the front all the way to the sacrum in the back can break, and if it breaks in two places, we consider that a pelvic ring injury. And what's relevant about that is we've then disrupted the relationship, the stable relationship between your hip and your spine. That's the bad news. But the good news is the hip joint itself, there's not really a joint injury per se, or at least not a hip joint injury. So arthritis and things like that are less of a worry for a pelvic ring injury. The other big category of injury, so pelvic ring injuries on the one hand, and the other one is an acetabular fracture. The acetabulum is a fancy term for your hip socket. So the hip joint is a ball and socket, and you can break the socket, and that's called an acetabular fracture. And these are just some pictures. On the right side, you see what we would consider a pelvic ring injury. This is what we would call an open book pelvis injury. It's one, we'll go through this in more detail, but where the ligaments in the very front of the pelvis disrupt and it opens up literally, as it sounds, like a book. And these can be quite severe injuries, but the good news is that they don't involve the joint, and so they don't tend to have long-term consequences for any joints. In contrast to the injury on the bottom, where the the ball of the ball and socket, the femoral head, has been driven up into the socket, and it's kind of shattered on that left side. And that is a complex injury to treat and can have really a lot of long-term consequences for the function of the hip joint. So we'll delve into a little bit more detail on pelvic ring injuries. So what are the different elements of the pelvic ring? So I talked about the fact that it's like a pretzel. It typically breaks in two places. That break can take on sort of one of two broad flavors. It can either be a ligament injury, or it can be a fracture, a bony injury of some kind. And it can usually occurs in the front and in the back. So whenever we see an injury in the front on an x-ray, we immediately start looking for where the injury in the back might be. The front injuries most commonly would be the pubic symphysis injury, like I talked about, in that open book injury, or they could be a fracture of the rami, which is one of the main bones at the front of the pelvis. That's what's shown. Let me see if I have a pointer here. Can you see that? So this would be, in this drawing, this would be the ramus fracture, and then this is a fracture in the back of the iliac bone. But again, its fracture occurs in both the front and the back of the pelvis. In the back of the pelvis, it's very commonly a ligament injury of the SI joint, the sacroiliac joint, or it can be a fracture, again, of the sacrum or the iliac bone. This picture on the bottom is showing a tear of those ligaments, of the sacroiliac ligaments in the back, and then a tear of the pubic symphysis in the front. So again, this would be another example of that open book type of injury. So how do these happen? What does it take to break your pelvis? And in general, we think of them as a very high energy injury. This isn't something that typically is happening in young people unless there is a really, really large amount of force. And most commonly would be a car crash. It could be a motorcycle crash, a fall from height, or getting hit by a car. It takes a whole lot of energy, generally speaking, to break the pelvis. And how it breaks, in terms of whether you get a fracture or a ligament disruption and exactly where it breaks, actually depends a lot on where the force comes from. And we actually classify them based on this. But typically, if the force comes to the pelvis directly from the front, like what might happen in a motorcycle crash or a car crash, that's when we would see that open book type pelvic injury, where you have the pubic symphysis disruption in the front and the ligament injuries in the back, and the pelvis just opens up and rotates outward. If the force comes from the side, like a car hitting another car, getting T-boned in a car from the side, or a high fall where somebody lands on their side, then we see a different pattern of injury. More commonly, instead of the ligament injuries and the open book injury, we get what's called a lateral compression injury, where the pelvis turns inward and you get breaks in the front and in the back. And we hold a whole classification system around this, and I'm not going to belabor this. I think it's kind of beyond the scope of this talk, but this is how we kind of classify. Within each category of direction of force, we think about there's kind of a spectrum of injury we see depending on how much force got transmitted to the pelvis. And this dictates, at the lowest end of the spectrum are things that often aren't totally unstable and don't even need surgery, whereas the ones at the higher energy end of the spectrum are more likely to be unstable and more commonly would require surgery. But we divide them into the lateral compression, which is the force from the side, the anterior-posterior compression, which is a force from the front, and then vertical shear, which is literally like in plane with your body. Usually this would be something like a fall from a really large height, 30 or 40 feet, and landing and directly, and it shifts the pelvis vertically instead of in either of those other two directions. But it's the least common of the three. So those are kind of the high energy pelvic fractures that we talk about. But what happens as we get older? Well, basically, these same injuries can happen, but you don't need nearly as much force as you would need at a younger age. So we can start to see pelvic fractures even from falls from a stepladder or falls even from standing as bone quality starts to get really, really poor. So in severe osteoporosis, just a simple fall from standing can lead to a pelvic fracture because the bone quality is so poor. Usually the types of injuries that we see are that lateral compression variant, because it's usually a fall from standing and landing on the side of the hip. And even though there's lower kinetic energy, that lower kinetic energy combined with poor bone quality can still lead to fairly severe fractures in some cases. Luckily, the majority fall on the less severe end of the spectrum, and this when it's just from a fall, but we still see the same spectrum of injury, even in older patients who have it from a lower energy mechanism. This is just a graph from a study. This was actually in Europe, but the bottom line is it just shows that we would consider it's a bimodal distribution. So pelvic fractures happen in young, crazy 20-year-old guys who are crashing their motorcycles, but then it peaks again later in life as bone quality becomes poor, and this just shows that and more common in women and men just because osteoporosis is a little bit more common. In the most extreme case, when bone quality is so poor, you can actually get what we call insufficiency fractures. They're not even associated with a fall. It's literally the bone gets so poor that you just spontaneously start to develop like a stress fracture, essentially, that most typically occurs in the sacrum, in that lowest part of the spine at the back of the pelvis. And these can be a cause of really severe lower back pain, and sometimes it's easy to miss, actually, because back pain is so common that it's easy to chalk it up to just run-of-the-mill back pain, but it can actually be this more severe problem. Again, because it's a bone quality problem, it does happen more commonly with increasing age. The good news is that it usually gets better with conservative treatment. It's usually a period of rest, just pain control, physical therapy, and early immobilization tends to be the mainstay of treatment. We rarely have to do surgery for this, but it is important to identify early because it is different than your typical lower back pain. So circling back to pelvic ring injuries and just shifting gears and talking a little bit more about treatment. Well, the good news is that the majority of pelvic ring injuries, and especially those that occur with older age, can be treated without surgery. And usually it would be something like, we even allow people to weight bear right away, but probably with some kind of assistive device, like a walker initially, and then as the pain settles down, can return and wean back to a cane or nothing. But there are some subset where if the front of the ring and the back of the ring, and remember the pretzel analogy, if there's just enough energy and the bone quality is bad enough, then you can get an unstable injury where both the front and the back are broken, then occasionally we still would need to do surgery in those scenarios. But luckily, it's a little bit less common. Now, acetabular fractures, remember this is the other broad bucket of pelvic injury that we see. These are the ones that are injury of the actual hip socket. These more often than not do require surgery if the pieces are not quite lined up. And it really doesn't take much. And studies have shown that even 2 millimeters, but you can just barely begin to see on an x-ray, but even 2 millimeters of the hip socket not being perfectly round can lead to a higher risk of arthritis down the road. And so we really have a lot, our tolerances for the bones being slightly out of place is a lot lower for an acetabular fracture than it would be for the pelvic ring injury because of the fact that it's involving the joint. But the problem is the exposures to get to the pelvis are, to the acetabulum to fix it, are very big. It requires these big open exposures to get all that anatomy we talked about at the beginning. We have to get that out of the way. And so this is just a picture of one of the common exposures that we would do to fix one of these fractures. It's an incision that goes up from way up on the iliac crest here all the way down to the pubic symphysis. It's a huge incision and a lot of exposure to get access to fix these. So that's a big distinguishing feature between sort of the acetabular fractures versus the pelvic ring injuries. So pelvic ring injuries, just in review, the bony injuries are a little bit more straightforward to fix. First of all, they often don't even need to be fixed, but when they do, we can often do it with small incisions and more limited exposure. And as long as the bone heals, the bone itself tends not to cause long-term problems for people, unlike the acetabulum, where you can develop arthritis down the road. But there's bad news with the pelvic ring injuries, and especially with the higher energy ones. They tend to be associated more commonly with other injuries. There can be head injuries, abdominal injuries. There's a much higher risk of significant bleeding because of all the blood vessels that are running right by the pelvis, like we talked about. And high risk of injury to all these other strutters. Bladder injuries and things like that are actually quite common. Also, the major nerves can cause foot drop or bowel and bladder problems. So there's a lot of, the bony injury itself for pelvic ring is often less worrisome than the associated injuries. In contrast, for acetabular fractures, and here's an example again, the fracture itself tends not to bleed so much. There's a rarely life-threatening amount of bleeding that occurs from an acetabular fracture. There's much lower risk of damage to the surrounding structures. It tends to be most of the energy of whatever fall led to this tends to go right into that hip socket and just create lots of pieces around the hip socket, but it doesn't tend to damage things around that area. So that's the good news. But the bad news is that they are very complex to treat. They require these large incisions and surgical exposures in many cases, and there's a much higher risk of arthritis in the long term due to damage to the joint. So just a couple of examples to run through to talk a little bit about, just to show you what the treatments kind of look like. This is a 61-year-old man who was riding his motorcycle, and he crashed and sustained this injury. And what we see here is in the front, there's a big gap in here between the two bones. That's the injury of the pubic symphysis, the ligament that attaches these two bones in the front. In the back, on the left side, there's a big, it's maybe hard for you to appreciate, but there's a big gap between the iliac bone over here and the sacral bone here. That indicates that there's been a tear of the ligament, those thick ligaments that hold the sacroiliac joint together normally. And there's also actually is a fracture over here that's very close to the acetabulum, though this one wasn't totally in the joint, even though it's quite close to it. And so the way we treat this one, so this patient was very sick when they came in, was a lot of bleeding. They needed a lot of blood transfusions, had to go to the ICU, need a lot of close monitoring, and to be resuscitated. And once resuscitated, went to the operating room and was able to fix the front just with a fairly small incision. That's a plate and screws in the front there that's holding that pubic symphysis back together where it belongs. This is a long screw placed along that fracture through an incision, a tiny incision of about 1 centimeter. And then these screws in the back hold the sacrum, or actually both sides were injured as it turned out. And so there's screws in the back that are holding those sacroiliac joints back together again. And that's all done through just little small incisions without wide exposures, using an intraoperative fluoroscopy, an intraoperative x-ray machine to guide and make sure that we have the pieces lined up again and make sure that we've safely placed the screws and not hit any of those important blood vessels or nerve structures or things like that. That's obviously very important. So that's kind of the fun part on pelvic ring injuries, is we're able to do things through relatively small exposures. This is just a contrast. This is a 71-year-old man hanging Christmas lights, not an uncommon story, unfortunately, and fell from a ladder about 5 or 6 feet and has this acetabular fracture. So this is on the right side, right here, and it maybe shows better on this other images that's rotated slightly. You can see that the ball of the ball and socket, the femoral head, has pushed up into that hip socket and split the pieces apart. And that's led to the socket's not a nice round socket anymore. It's broken into some pieces. And so in this case, had to do a much bigger exposure. So it's that same, we call it ilioinguinal, but it's this big long incision that wraps almost halfway, a quarter of the way around your body. big wide exposure. We have to kind of expose those big blood vessels that go to the leg and make sure everything's safe and protected. And then we use these plates and screws to put it back together. And so we are able to, very accurately reconstruct the hip socket, but it does require a lot more exposure, and the surgery is probably more risky in many ways than the fracture itself, which is a big contrast to the pelvic surgery. So what's on the horizon, things that are kind of new in the field of pelvic surgery? I think one that's really exciting is the use of intraoperative CT scans. So I mentioned that we use intraoperative x-rays a lot, but that's a two-dimensional image. Now we have these, it's called the O-arm. It's literally like a big O, so we can do a three-dimensional scan of someone's pelvis during surgery. That allows us to check and make sure that things are back in place where they belong, check and make sure the hardware is where we think it's supposed to be. And there's even a thing called navigation, where you can actually register your instruments to a machine using that three-dimensional CT scan, and it can help guide you with a computer and make sure that you're placing everything in very precisely in bone where you'd like to put it. And so I think that this is something in the future that's going to allow us to increasingly do less and less of these big exposures and do more and more through smaller incisions. The other one, and maybe it's crossed someone's mind, is so when we're talking about the acetabular fractures, well, why not just do a hip replacement? It sounds very simple. And another important distinction that hopefully has been clear is that when we talk about hip fractures, this isn't the hip fracture that we're talking about. When people talk about hip fractures in general, it's talking about a break on the femur side of the ball and socket, on the ball side of the ball and socket. So those are at least 100 plus times more common than these acetabular fractures. But these socket fractures are much more complex, because when it breaks right below the ball, which is very your typical hip fracture, it's very easy to just do a replacement. The hip replacement essentially, even for arthritis, they just take the ball out anyway. So it's almost like the fracture does the work for you. So it's very easy to use total hip replacement for treatment for that. For acetabular fractures, though, unfortunately, it's much more difficult, because the way the hip replacements work, the socket replacement has to sit into the bone and be able to get fixed to the bone very well. There's not much that you cut out. It's almost like a resurfacing. And so if the socket is broken, then the pieces won't have anything to hold on to. And so there is a push now towards trying to combine, since there's such a high risk of arthritis with some of these fractures, to actually fix the bone and replace at the same time. And we're trying to combine this with some of these more percutaneous, limited small incision approaches to fix the bone and then do the hip replacement. And that can really be a way of kind of dealing with all the problems at once. But these are kind of things that are still evolving, but things we're thinking about for the future. So in conclusion, it's a really complex anatomy that surrounds the pelvis, which leads to complicated multi-system injuries and complicated surgeries to try and reconstruct. They do increase with age, and that relates to osteoporosis and poor bone quality. There's a big spectrum of injury, and luckily the majority, especially among older patients, the majority can be treated non-operatively. But there are a subset that are unstable and may require surgery. And of course, we talked about the acetabular fractures. That's a whole different category. That's a break of the socket of the hip joint. They're more complex and have a higher risk of arthritis. That's all I have. Thank you.
So I'm not just going to talk about fractures. I'm going to talk about, this is a potpourri of a lot of different things related to the spine. I trained at Vanderbilt and did my orthopedics at the University of Michigan. I did my trauma fellowship here and my spine fellowship down in Los Angeles. I've done one thing perfectly in the world. And when I was in the first grade, I achieved perfect attendance. And at the end of that year, I said, you know what? I'm going to try to keep this record up as long as I can. And I've never missed a single day of school or work in my entire life. I'll be 65 in January, so I'm really lucky, very lucky. And I just came across a book that I found very interesting. How do you live a long life? Well, you know, people theorize, and there's a Stanford longevity project. But really what the punchline here is that if you work really hard and you engage in a pursuit of a goal, you'll live longer than if you just dilly-dally around and don't do anything and you're happy-go-lucky. So maybe I'll live a really long time, but this book is really good, so I would advise people to maybe get it and have a read. So I've got multiple passions that I'm really excited about, and that's I work 7 days a week. One of my passions is my ranch out in the Central Valley, and we have a bunch of horses out there. It's a commercial operation, and I'm a pretty good stall cleaner, which is very hard work. But I'm used to it because I grew up on a farm in Tennessee. I'm also one of the team doctors for the Pro Rodeo Cowboy Association and the professional bull riders, and they get injured every 8 seconds or less. It's an extreme sport. It's very popular. It's a popular spectator sport. There's usually 30 or 40,000 people in the audience. But the three rough stock events are bull riding, bareback, and saddle bronc. And I'll show you what we did in a study with the bareback riders, which is the bottom right. They're subjected to extreme whiplash forces that you won't really even believe. There are 3 things. This is probably going to get me a little choked up. What I wanted to do, you know, you often hear people say they want to make a difference in the world. And so I gave a lot of thought to that. How could I make a difference in the world? And, you know, day to day we do orthopedics, and you affect people's lives on a day-to-day basis. But what happens when I'm not here? And so I wanted to create a fellowship, a graduate medical education fellowship, and I named it after my daughters. And Dave can maybe explain it a little better, but I created this international research fellowship with the purpose of training our future young orthopedic surgeons so they could go out and perform research projects, teach other orthopedic surgeons in these under-resourced countries, and make a difference in the world. And this is a sustaining thing that'll be here long, hopefully long after I'm not here. And I've pledged $250,000 of my own money, and I'm gradually chipping away at it. And I've got some brochures here I'm going to pass out if anybody wants to put $1 in there. But this is something that I'm very passionate about. And Dave, I think, is headed to Tanzania tomorrow? Friday. We have 3 of the Orthopedic Trauma Institute, which is part of UCSF, has multiple outreach sites. So Dave and Sam Morshed and Amir Matitiyahu are on a plane to Tanzania for 10 days to do courses and do some really good stuff. I'm very proud of those guys for doing that. And we have a fellow every year. We've done this since 2012, and the fellows that have gone through this program have achieved a lot, and I'm really proud of them too. And hopefully this will continue forever. So what we're going to talk about is a bunch of different things related to the spine, and we'll go through a little bit of anatomy, a little bit of biomechanics. What is an injury? Whiplash, spinal cord injury, disc herniation, because that's, you know, a common problem, as well as some fractures. So in the spine world, there are 3 things that you have to do. You have to take a history, you have to perform an examination, and you have to do imaging studies. You can't make a diagnosis without all 3 of those. So people will come up and say, hey, Dr. McClellan, can you look at my MRI and tell me what you think? Well, I need to know what the history is, and I need to know what the examination shows. You can't really give them any information based on just an imaging study. The physical exam is very important because I know the wiring diagram. There's certain nerves that go to certain distributions, whether it's a sensory nerve or a motor nerve, and you can examine those specific nerve roots to determine if there's an injury to that nerve. So the anatomy of the spine is repetitive. There's vertebral body, disc, small facet joints. If you look at a cross-section of the spinal cord or the spine at the cervical level, the disc is made up of a nucleus, which is like a jelly, the outer covering or the fibrous ring, the vertebral body, and then those holes on either side is where the artery is that goes to the brain. Then the nerve root comes out in that little foramen or hole. The spinal cord is in the middle there, and then there's an arch or a roof over the top of the back of the spinal cord to protect it. The spinal cord ends at about T12, L1, so there's no spinal cord below L1. So the lumbar spine, your lower spine, again, is a disc, vertebral body, vertebral body repetitively, and then the nerve roots come out again as paired structures at certain levels and go into a particular distribution into your lower extremities. This just shows the ligaments in the front and the ligaments in the back of the spine that hold the vertebral bodies together, and they're very strong ligaments. It takes an incredible force to tear them, and then the spinal cord is protected in the bony, ligamentous bony structure of the spinal column. So what is an injury? An injury, we need to know what a clear definition of an injury, and it's sort of there are multiple theories on what an injury is. Like most diseases, injury is defined by the causative event and what is the resulting pathology. The simple orthopedic definition is a mechanical disruption of a biological tissue resulting in pain. Well, what's pain? The Marines say that pain is weakness leaving the body. And that's what the Cowboys say. I tell the bull riders, if you didn't have any pain, you'd be lonesome. So that's the simple orthopedic definition, but really there's a very complex pain pathway. The epidermis has nociceptive receptors in the skin that are activated by some tissue injury. The signal travels through the peripheral nerve. It gets through neurotransmitters. It goes to the thalamus, and then in the thalamus it goes to the somatosensory cortex, the frontal cortex, and the limbic system. And so pain can be perceived, there's chronic pain is a very complex thing. There's an emotional piece, there's a sensory piece, there's a thinking piece. So that's why chronic pain is a difficult problem. There are multiple theories of injury. These are just a few of them. And just to talk about the top one, the multivariate interaction theory, there's a bunch of stuff that can happen, both genetically, morphologically, psychosocially, as well as biomechanically that can result in, injury causation. So injury is a serious public health issue. One person dies of an injury every 3 minutes. There's more than 2.5 million people that are hospitalized with injuries. 31.6 million people are treated in the emergency room, and more than $465 billion is spent annually in medical costs and lost productivity. So what about whiplash? Whiplash, everybody knows what whiplash is. Well, is it fake or real? And it's not uncommon for patients that are involved in a rear ender to get an MRI very quickly after the accident, and it almost always shows something, and then there's the issue, what was that caused by the accident? Well, there's a bunch of studies that have been done that show that probably those changes are not related to the accident. This is a study that was done by a radiologist. It was published. It was a prospective study. And what they did, they took 100 consecutive patients, and they had an MRI within 48 hours after the accident, and then they matched that to 100 matched controls. They had 4 people that had no idea whether it was a whiplash person or an age-matched control, and there was really limited to no evidence that the findings on the MRI were related to the whiplash. There was basically the 2 MRIs were very similar. Again, this was a study that looked at long-lasting symptoms following a whiplash. It was a prospective trial with a one-year follow-up, and what they found was that pre-existing degenerative changes was not associated with a prognosis. MRI rarely gave you an answer to a diagnosis. Getting early MRI scans didn't predict a prognosis. So bottom line with this study and with multiple others is that, you know, the MRI alone is not really your answer for diagnosing what might have happened with a whiplash. This was a study that actually won an award. It was done about 20 years ago. They took 21 volunteers, subjected them to a 14.2 kilometer rear end accident, which is equivalent to 3.6 Gs. They examined them and did MRIs before and after this accident, and there weren't any symptoms or changes on the MRI. Now, obviously, the volunteers knew that something was coming, and that's 3.6 Gs is not very much. You know, that's less than basically 10 miles an hour. So what I wanted to do is say, what would happen if I exposed a human to 10 times that force? And you're going to say, well, who's going to volunteer to 36 Gs and be happy about that? Well, I got the rodeo guys. We took the bareback riders, and I don't know if you've ever seen a bareback rider, but they're laid out like this, and the horses buck so hard that they're whiplashed like crazy. This was an IRB-approved study. We had volunteers. It was also a concussion study. That's me with some of the Cowboys. You know, they're young and tough, just like me. We actually did a lot of stuff before. We examined them. We had them fill out surveys. We did MRIs right before and right after. And the really cool thing is we did G-force calculations with this accelerometer. So we put accelerometers in their mouth so we could measure the linear and the rotational G-forces while they got bucked, okay? This is one of the riders before he actually got on a bucking horse. You can see he has a very large herniation at C6-C7. He was totally asymptomatic. Most surgeons, most people would say, you better not get on this horse if you've got that. But he said, I've never had a problem with my neck. Here's his G-force data. He was exposed to a peak of 35 Gs, okay? Here's his MRI right afterwards, or the next morning. Really no difference. Here are the two MRIs side by side. This was read by radiologists. No difference in the two MRIs, despite a large herniation pre and post-ride. So we had 21 guys that we did this with. The mean acceleration was about 24 Gs. One of the riders peaked at 62.8 Gs. Really, there was no real difference. The post-ride neck scores were a little bit higher, but there was no arm pain, no radiculopathy, no real change other than a little bit of bulging in the disc before and after. So really, this study was significantly more severe as far as the G-forces in that other study. So how do you treat a whiplash? Well, this was 20 years ago. Really, it's minimal intervention, reassurance, encouragement, simple exercises. Don't get an MRI every 2 or 3 weeks because it's not going to make any difference. You've heard the phrase, no pain, no gain. Well, if you go back to work early, and you will tend to maintain your treatment gains if you're rehabbed following an injury to the neck. So this was a study with 1-year follow-up. 73 had returned to work, 37 were disabled. The participants who returned to work were more likely to maintain their treatment gains than those who remained work disabled. So when patients say, well, I can't go back to work, I just say, well, if you go back to work, you'll maintain what treatment goals you've realized if you get back to work sooner the better. Just a couple comments about impairment and disability. This comes up frequently with back injuries. Impairment is actually a loss of physiologic or functional or psychological function due to injury. Disability is loss of limitation of work or opportunity to take part in society. A judge makes a disability determination. A doctor makes an impairment recommendation. The reason this is important because this is very common in the spine world. Patients think they're disabled when in fact they have very little impairment. Lower back pain, again, is the top cause for years lost due to disability. There are multiple studies in many different countries that show that the global burden of back-related issues is humongous. Social Security receives more disability applications for back problems than any other physical illness or injury. So let's talk a little bit about biomechanics. So how do you evaluate injuries? We can do mathematical modeling. We can do cadaver studies, human volunteers. You've seen those studies. You can put, the car dummies in there. If you look at the spine, it breaks down into several segments. One is the thoracic spine from T1 to T12, and that's fairly rigid. It's supported by the rib cage. There's a curve that is called a kyphosis, sort of a hunchback, and usually flexion injuries predominate in the thoracic spine. At the junction between thoracic and lumbar, there's a transition between very stiff to very mobile. Most injuries occur at the junction between the thoracic and lumbar spine, and then there's the lower spine from L3 to the sacrum. And the lower spine is very mobile, and usually axial loading injuries predominate there. Again, this is just a biomechanical testing machine that we can create constructs in cadavers and test the loading and the structural rigidity of our constructs. This is an interesting study, and I don't know how many golfers there are out there, but we're going to talk about some what happens to your back when you play golf, and we'll talk about what Tiger Woods had. But if you lift a load of 20 kilograms bent forward slightly, there's a 4.5 increase in disc pressure in your back, just lifting a 20 kilogram weight bent forward a little bit, 4.5-fold increase in disc pressure. So the pressure actually increased after that person was, the monitors were placed in the disc. That pressure actually increased after they'd been lying down for 7 hours, and that was presumably due to rehydration of the disc after they went to bed. So this is a dummy model. The cars do all this testing with safety restraints and headrests and stuff. All the new cars after 2012 required a head restraint, or 2010, whatever it was. So there's fewer whiplashes. So car crashes are not uncommon, and this is some of the numbers that it takes to create an injury. A vertebral compression fracture can occur, or a fracture dislocation can occur with a 20 to 40 G load. You can have a pelvic fracture with a 100 to 200 G load, and your body can fragment with 350 Gs. Now, this is a little bit different than the Rodeo study that we performed, but this just gives you an idea of what G forces can happen. What can occur with certain levels of G-forces. So why is back pain so common in certain athletes? Golfers are the most notorious victims of back injuries, and I'll tell you why in just a minute, but most of the tour professionals will have a neck or a back injury. Tiger Woods was crippled with his L5-S1 disc because in fact, he couldn't play anymore. He had multiple surgeries until he had a lumbar interbody fusion. And the reason the back is subjected to so much load is you're bending forward, there's torsion on the disc, and this repetitive loading, that's one of the theories of injury. This repetitive loading produces injury to the disc. This was a study that looked at the compressive, shear, and lateral bending and rotational loads at L3, L4 with one golf swing. So with one golf swing, there's 8 times body weight through the L3, L4 disc. So imagine a guy like Tiger Woods who swings a golf club hundreds and hundreds of times a day and experiencing 8 times his body weight through the disc. So you can understand why that would produce an injury. So this goes to the cumulative load theory. So it's a repetitive cumulative load to the lower disc that results in this injury to that disc that causes the pain. There's probably a good reason that women live longer than men, and you'll frequently hear the term fracture or broken. It's really the same thing, and a fall from a height like this will almost guaranteed result in a spinal fracture and potentially a spinal cord injury. So spinal cord injuries are pretty significant. Most are from vehicular accidents and falls. We see a few from gunshot wounds, some from sports. I've seen bull riders with broken necks and broken backs. As of 2015, there were about 12,500 new spinal cord injuries each year. And between 240 to 337 people are currently living with a spinal cord injury in the United States. So just a couple of examples of fracture types. This is a burst fracture, which means the vertebral body just explodes into many pieces. And we sort of classify burst fractures as to whether they're stable or unstable. The ones that are stable can be treated in a brace called a TLSO because they're not going to tend to fall apart or cause neurologic damage. This is an example of a CT scan of somebody with an L1 burst fracture. He was neurologically intact. In other words, the nerves were working totally normally. So we felt like he could be treated in a TLSO. Unfortunately, in follow-up, he started to kyphose or collapse. The bone collapsed more, and he developed a deformity there, so we ended up putting in screws and rods to stabilize his spine so that it wouldn't collapse anymore. So this is another type of fracture called a flexion distraction injury, where it tears ligaments and bones, and the bone, it goes all the way through the spinal canal. Many of these result in neurologic deficits. In this particular patient right here, this was a young girl who was in a car accident, and it looks really bad on the x-rays on the left, but amazingly she was neurologically intact, and we simply fixed that with 2 screws at the level above and 2 screws at the level below with some rods. This is an unfortunate young girl who was sitting in the seat with her boyfriend in the front seat, and the car flipped and she broke her back. This is at L3, I guess, which is below the level of the spinal cord, but she had a complete spinal cord injury because at the time of impact, when she was thrown out of the car, this is a static image, so there was probably way more displacement of the bone, and it just shredded all the nerves from the lower spinal cord. So, we still fixed it so that she could rehab and get through that as well as possible with as little pain as possible. But she ended up with a complete spinal cord injury. This is a fracture dislocation. Again, there's almost all of these result in neurologic deficit if they're at the spinal cord level. Almost all require surgery. And this is a lady that actually we're getting ready to operate on here at UCSF. This is a lady I treated 20 years ago, and she was in the back of a pickup truck, fell asleep, or was in the back of the pickup truck, and the driver fell asleep. The truck rolled multiple times, and she has a fracture dislocation. You can see the red lines and the yellow arrows show that the vertebral column is obviously not very well lined up, and tore her spinal cord. We still fixed her, but she actually has developed a problem below the rods and the hooks with severe degeneration, so we're going to revise that, and this was done 20 years ago. Here's a person with an L3 burst fracture. This is the MRI showing the spinal cord getting sort of pinched, or the nerves getting pinched, not the spinal cord because there's no spinal cord, and then the bone fragments in the canal on the far, your far right. And this was fixed where we took the the fractured vertebral body completely out. We put an expandable cage in and then put screws and rods in the back to stabilize that. This is the vertebral compression fractures, which are common in elderly. They can result from almost no injury, just a cough or a simple slip and fall, or they can even occur spontaneously. They are incredibly common. We see about 700,000 of these per year. A lot of them are not even diagnosed because the person has back pain, but they don't even go to the hospital, and they just assume that they're old and they've got back pain. But there are quite a few hospitalizations related to compression fractures every year. There are a lot of causes or risk factors to vertebral compression fractures, including age, osteoporosis, steroid use, smoking, and some of these other things. Malnutrition, alcohol use, and a sedentary lifestyle are all risk factors. And in fact, if you look at vertebral compression fractures, if you have more than, they can frequently occur in greater than 1 or 2. So if you have 3 or more, that's equivalent to having a stroke or cancer as far as quality of life. This was a study of 334 people that were 65 that had more than 3 VCFs, and their quality of life was not good. So if you look at risk following a recent fracture, 20% will experience another fracture within the first year. So if you get one, you have a 20% chance of getting another one within the first year. We're going to move into the final topic here of pinched nerves. This was a large study out of the Mayo Clinic that looked at cervical radiculopathy, or a pinched nerve in the neck causing arm pain. They looked at 561 patients, and the interesting thing is that most of these patients, 14.8%, only 14% could recall any history of exertion or trauma. So the vast majority of patients with a cervical radiculopathy or pinched nerve in the neck causing arm pain, the vast majority have no history of trauma or any history of exertion. They occur spontaneously. Thank you.